normal dichotomous branching. But if you see the choroidal circulation, they are more like kind of a parallel pipe appearance. So several parallel pipes which drain into the vortex veins. So maybe because of a difference in the drainage patterns, this may affect the choroidal circulation more as compared to the retinal circulation. And the pathogenesis now being proposed is that there is an intrinsic or an extrinsic effect on the venous loading that results in increased venous pressure, that results in venous remodeling and intervortex anastomosis, which increases choriocapillary pressure overloading, may lead to increased leakage or a decreased perfusion leading to ischemia. And then the effects may vary. If the eye has been able to compensate these changes by ability to egress the fluid through the sclera, it may become normal. However, if that ability is not there, then it may result in leakage to the RPE detachments, followed by fluid, followed by presence of a neovascularization. So to conclude, the term pachychoroid is probably just an epiphenomena rather than the etiology. Venous insufficiency intrinsic or because of intrinsic or extrinsic factors, some of which we really do not know, whether there are local factors, whether the sclera plays a role, because in our own pilot study, we did find that patients with CSC had thicker scleras compared to patients with PCV versus AMD. So whether there are intrinsic or extrinsic factors that play a role, but basically there is some obstruction to flow at the vortex vein level, and the mechanisms causing the venous overloading are variable, but a defined pathophysiology may allow for maybe better methods of repair. As of now, how this is going to change our practice paradigms, management paradigms, we're still not very sure. But yes, it kind of is terminating into a chronic venous insufficiency. Thank you.
Thank you, Diksha. If I can extrapolate into simple words what you have said, is that on OCT, you see thickened vessels, there may be overlying serous fluid, there may be multiple PEDs, there may be abnormal new vessels, and there may be choroidal excavation. But the bottom line is that you have thick choroid and you have compression of the choriocapillary. You showed beautiful ICG. Do you think a comprehensive ophthalmologist actually needs to do ICG to diagnose pachychoroid?
No, ma'am. I think an OCT is enough to diagnose the pachychoroid, but the ICG is not really needed for that. But this is just, I've made the pictures just to give a presentation and to show what actually the findings are.
So why is it important for them to know about pachychoroid? Because you said we are not sure about the management. So what is the take-home message? That if they see these thickened vessels, what do they do?
No, ma'am, it's that
suppose there is a PED with pachychoroid. Yeah. What should they do?
So if there is a PED with a pachychoroid, first thing that not all of those PEDs are going to be CSC. It could be a spectrum of PCV also. That's one point. And then if they need to follow this up and look at the development of fluid, there may be sometimes underlying a neovascularization, which if they can detect, maybe on OCTA if they have, or maybe in that situation they may need an angiogram. But otherwise, I think the relevance as to how this is going to change our management is not yet clear.
But it's also important to know this, because if we label it as AMD and start them on monthly injection of Avastin, sometimes in pachychoroid that really doesn't work.
And patients who are chronic CSC, like where we don't have anything to offer, if we see a thick choroid and presence of long-standing fluid and we rule out neovascularization, maybe they may be candidates of doing scleral windows.
And also, I think don't get intimidated with retina surgeons making the diagnosis of pachychoroid and you feeling inadequate that you could not make the diagnosis. It is honestly, nobody knows. It's just a thick choroid. So there is no need to get intimidated, but there is a need to know about these things. Now, Diksha beautifully mentioned about polyps. Like if you see, you can see sometimes the polyps, and polyps would be one of the in the spectrum of pachychoroid. Now, SIMAR is going to extend it to see that suppose you are seeing polyps, how does it affect your management? So over to you, SIMAR.
Thank you so much, ma'am. Thank you for having me. in this course. Can I have my slides, please? Thank you. I can't see them over here. That side?
So while SIMAR is fixing up, the polyps may be seen in patients with AMD. They may be seen in pachychoroid, or they may be seen standalone. So what SIMAR is mainly going to tell you in AMD context, because that's what we see most commonly. So if we see there are polyps, how do we proceed? No? So, Anirudh, would you like to give any comment? Okay, we get it after this. Fine.
Can just resume this slideshow. All right, I can present like that. That's fine. So I'll just be showing some very practical cases that we see in a daily clinic, and how that changed my management on seeing some particular case, and how seeing the polyps actually mattered. So polyps are aneurysmal dilatations of the inner choroidal vessels, and they are seen usually at the end of a branching vascular network, and they are characteristically seen in patients with polypoidal choroidal vasculopathy, which is part of the spectrum of the pachychoroid spectrum. And ICG angiography still is the gold standard for the diagnosis of polyps. So this is the PCV diagnostic criteria as given by the Everest trial. And so this mentions that the focal hyperfluorescent lesions appearing before 6 minutes on ICGA, plus at least one of the following, which are the secondary criteria, is essential for making the diagnosis of PCV. So polyps are very essential to the diagnosis, and so is the management of the disease, as we will see further. So this is my first case, which I saw just a week earlier coming from here. 72-year-old male came with complaints of sudden decrease of vision in the left eye for the last 2 months. No history of prior ocular trauma or surgery. Suspected case of pancreatic malignancy under evaluation. Known case of benign renal cyst. No history of diabetes or hypertension. This was the right eye, which was essentially looking normal. Patient had a good visual acuity. This was the left eye, with the patient was 636. You could see a pearly white mass temporal to the fovea, some hemorrhage. So just on looking at it, the first thought in my mind when the patient had given so many cards, shown his history, probably maybe a metastasis over there, but something was not quite fitting. Then there were these lesions that were just superior nasal to the fovea. You can see those reddish lesions over there, which were again not adding up to the picture of that. Or both eyes autofluorescence and OCT, which shows you some chronic changes of RP changes in the autofluorescence in the left eye. Right eye, there is one focal area of hypoautofluorescence, but rest of it looks fairly normal. This is a closer look at the OCT of the left eye, where you can see this large fibrovascular PED, which has kind of a notch-like appearance, and this PED over here, which again has these roundish structures just beneath the peak of the PED, or the thumb-shaped PED, and this double membrane sign over there. And then again, some more scans to just show the fibrovascular nature of the PED. So we were suspecting that this could probably be PCV. So this is the video ICG that we ordered to document that. And if you look at the ICG angiogram on your right side, you can see that within the about 15 seconds, the branching vascular network starts filling up over there. And you can see those pinpoint hyperfluorescent lesions, which are kind of expanding now, both in the area at the top of the hemorrhage and the area on the nasal side. So this will just show you in still frames the same thing. The area that was superior nasal to the reddish lesions that we were seeing, those were also polyps. And just in that large area nasal to that, also there was the branching vascular network and the polyps. The right eye, the ICG showed some changes, but I'm not sure how to interpret these given the context that the left eye has, we have seen polyps now. So this was the multimodal imaging of the patient. OCT angiography, there's a lot of fuss about it, but given that I had seen the polyps over here, I can say that yes, these are polyps on OCT angio. But had I seen just the OCT angio, it would be difficult. But yes, when you see the flow map and the OCT of the cross-sectional OCT flow map, you can see these lesions that was seeing as the humps on the PED, that you can see this flow also over there. They were probably the polyps that were showing up. We made a final diagnosis of PCV, treat and extend with aflibercept for with ILIA, and watchful observation for the right eye. Coming on to a case that had some longer treatment, again a 54-year-old female complains with decreased vision for 2 weeks, no prior ocular trauma or surgery, hypertensive. She presented with this, the right eye, which was essentially again normal, and this in the left eye, where you can see this large bleed at the posterior pole at multiple levels. You can see the this reddish color of the bleed, which was likely subretinal, and this lighter color of the bleed, which was going more extensive, that was likely sub-RPE. So looking at the bleed, both of them are subretinal, but probably in different compartments. And on OCT, the right eye did not have much to say about. The left eye, you can see the various compartments of the bleed as we were seeing. This was the subretinal component. Again, this notched PED and this this hemorrhagic PED going right up with the sub-RPE bleed. So again, in this case, we had PCV right at the top of our mind, but also hypertensive query, ruptured arterial mechanism. But with so much of bleed, we didn't go ahead with ICG right at that point, because that would have occluded everything. We gave 3 injections of aflibercept in the patient, and this is the follow-up on 3 injections. You can see that hemorrhage going away and the PED is flattening out. At this point, we did the ICG. The right eye again did not show much. The left eye, if you have a look, you can see this again. This is kind of a partially treated PCV, so that branching vascular network is also crenated, and these polyps are also kind of regressing in this case that you can see. So this is the branching vascular network that I was talking about, and going forward, they light up a little more as we go on towards the later phases, and then wash out towards the late phase of the angiogram. So again, treat and extend with ILIA. I'll show you the follow-up of this patient. So this is 1 year follow-up of meticulously following treat and extend. The patient vision improved to 6-9 parts from what she came to us with counting fingers, and had now complete flattening of those PEDs and the good anatomy of the posterior pole. So knowing that you have polyps, documenting them helps you confirm the diagnosis and counsel the patient better, because PCV patients tend to have more asymmetry than AMD, and they tend to present with a precipitous visual loss. And if you were to leave them on a PRN regimen, they might come back with a very precipitous vision loss, which you may not be able to recover then. So it is important to keep them on regular follow-up, and probably treat and extend is the best regimen for them, rather than PRN, which we will be following for majority of our AMD or DME patients. So just one more case, if I have time quickly, I'll go through. I have some time. So this was a 79-year-old gentleman. He was a diabetic, came with complaints of low vision in both the eyes, right eye more than the left eye, diagnosed PDR elsewhere, and some amount of left eye PRP had also been done. This was the right eye. You can see a dense vitreous hemorrhage, nothing much to see more than that. And this was the left eye of the patient, where you can see for which the patient was diagnosed with proliferative diabetic retinopathy and treated with PRP. I'm going to go into some closer images. You can see some exudation beneath the retina, and this was suspected as a NVE, which was the cause for treatment with the laser. And if you take a look at the inferotemporal area, you can see this multiple mounts similar to what we saw in the other case. This component, which is brighter red, is likely subretinal. You can see the vessel going above it. This component over here is sub-RP. You can see the darker red color because it is covered by the RP. And these some suspected orangish lesion. I know the diagnosis, so I'm suspecting them. Clinically, I did not, but I could see the various levels of the bleed that were present in this case. So it is not a subhyaloid or a pre-retinal bleed that we would typically see in a diabetic patient. And this was the infero-nasal, again some bleed in the subretinal and the sub-RP space, and some amount of fibrosis, which indicated that there was probably some subretinal fluid, and that had resolved subsequently, which left that subretinal fibrosis over there. And the laser scars, of course, you can see over there that had been done. So looking at this picture, this was definitely not looking like diabetes. So we kept a clinical diagnosis of PEHCR, peripheral exudative hemorrhagic chorioretinopathy, which is kind of a peripheral variant of PCV, and planned the patient for an ultra wide field autofluorescence and ICG angiogram. So this was the ultra wide field FFA. Uh, Again, it shows staining. Most of it does not add much information. Some leakage in the temporal half in the late frames, but doesn't give you very typical lesions of it. But now we have this ultra wide field angiogram, and we saw some nice pictures with ma'am also. And you can see in this, once you go forward, you can see some of these spots lighting up over here. These light spots are likely the polypoidal lesions which are present, which are lighting up again in the relatively early phase of the angiogram, some masked by the bleeds that are over it. And in the late frame, obviously they kind of wash out towards the late phase. This was the OCT, just some subretinal deposits present at the posterior pole. And this was the OCT passing through the peripheral region over there. So if we plan this patient for treat and extend with ILIA, right eye pars plana vitrectomy. Can I have just one more slide? Yeah, so this is the follow-up of the left eye patient after 3 injections of ILIA, kind of fibrosed, and you can see the posterior pole almost cleared up completely over there. And the right eye after vitrectomy, you can see similar lesions in the right eye that were present. So the right eye also had a similar course and bled into the vitreous that caused a breakthrough bleed. So in this case, just my learning points are that PEHCR could be a peripheral variant of PCV. Polyps can be documented in these patients also now with wide field ICGA, and recurrent and massive bleeds are known presentation of PEHCR, and it proceeds from the periphery to the center. So timely treatment can preserve central vision in these patients. Thank you.
Thank you, SIMAR. SIMAR, you showed very beautifully that polyps can be documented on OCT by the PED with the double head hump sign,
Yes.
or if you see a sharp PED.
Thumb-shaped sharp
And
bleed.
you also showed that clinically, if you see bleeds at different level, different colors, fresh, old, dark, something even looking like a choroidal mass, so you suspect polyps.
Yes.
And you said that if there is polyp, it's better to treat and extend rather to give PRN treatment. My question to you is, you detect a polyp incidentally, either in the opposite eye of AMD or just in both the eyes. There is no fluid as yet. Can you do anything to prevent the bleeds from the polyps?
So, ma'am, at that point, I would talk to the patient. I would tell them that this. I always tell them in these cases also that you have the tendency to have this in the other eye also. So, any disturbance, any distortion, you come to us early. At that point, if the polyps are not subfoveal, I would consider doing some focal laser to them so that I can regress them there and then. But without fluid, I would not treat at that point of time. I would wait for some activity to show up and probably follow up that patient closely.
I think that becomes very important if you are diagnosing polyp, whether it is incidental or in the opposite, apparently normal eye of the patient. The counseling is very important. The patient should be aware that there is something which might be impending. Laser or not is your choice, and we will not go into that area, but a close observation and counseling is very important. So with these two talks, we did hear about pachychoroid and how to look at the polyps. Yes, Saurabh. For some of you who are standing at the back, there are rows in front. Please feel free. Yeah.
So you showed some very interesting cases, Dr. Simar, and in most of them they were more severe. So if you have a polyp, a PCV case in which there's not much of a bleed and just mild fluid, do you always recommend 3 loading doses, or in those cases maybe you can just give one anti-VEGF and then see how it goes on from there?
So I would prefer to give a loading dose because that has been shown in the clinical trials with a better effect, and we have better evidence for that. But then at the end of the 3 doses, it is up to you to do a clinical activity assessment and then extend the treatment further. But I would prefer to give 3 loading doses.
So it would be similar for any kind of severity of PCV.
Yes, sir. Because that's the best evidence we have for it.
Thanks.
Can I ask a question? Sorry.
Yes, sure.
To SIMAR. It's about the third case in which you did a vitrectomy, you said. What was the need for vitrectomy? Because there was no vitreous hemorrhage?
What was the?
Was the indication for the vitrectomy?
He had vitreous hemorrhage.
In the PSCR,
Right
what
eye
was the
had
indication
vitreous
for the
hemorrhage.
vitrectomy? In the
In the
PSCR,
PHCR?
case, yeah, you should
What-
because that vitreous works as a depot for that ilia. If you remove that depot and the fovea is spared, then what's the logic for doing that vitrectomy?
He had a bleed.
In a PSCR,
I think
PHCR, the
there
patient
was.
had a dense grey vitreous hemorrhage.
I think he showed two eyes. Right eye had vitreous hemorrhage with proliferative diabetic retinopathy. Left eye also had the laser done for proliferative, but media was clear. He did not do vitrectomy for left eye. He did it
So
for
the
right eye.
that presented with dense vitreous hemorrhage,
I-
that was vitrectomized, and that showed similar lesions of PHCR in the periphery. The left eye, no vitrectomy was done.
Thank you.